We're here with Dr. Gerald Berke, our scientific advisor for Dysphonia International, formerly National Spasmodic Dysphonia Association. Dr. Berke did a wonderful webinar with us, and today we're just reviewing some of the questions that we were not able to address live during the webinar. So thank you, Dr. Berke, for being here with us today. We appreciate it.
Oh, sure, of course.
And so we wanted to start today a little bit talking about surgical procedures that are available for different forms of spasmodic dysphonia.
Yeah, okay.
So the first one we wanted to talk a little bit about is thyroplasty. Could you tell us a little bit more about the thyroplasty 2 procedure for adductor spasmodic dysphonia and whether or not it's being done here in the US?
Sure, certainly. I think the first thing to realize is that it's not a new operation. Dr. Ashiki, who kind of pioneered thyroplasty, started these. There's 4 types of thyroplasties, and this particular one is called type 2 thyroplasty. And it's been around for maybe, I believe it or not, 30 years or so. And as a treatment for spasmodic dysphonia. And I personally don't recommend it for a couple, I think, really good reasons. Number one, there's very little evidence that it actually works. In fact, I just did a muscle revision on a man who had it a while ago, and it didn't work on him. And I used to do it right when it got started, and found that number one, the patient's dystonia really didn't improve. Spasmodic dysphonia is a rare condition in Japan, and many of the patients that underwent the procedure were really muscular tension dysphonias. They weren't true spasmodic dysphonias. It's not a disease of the cartilaginous structure of the structure that holds the vocal cords. It's a neuromuscular disease, and basically the operation separates the thyroid cartilage to bring the vocal cords farther apart in an effort. But the problem with that is the vocal cords are in spasm, and just because you push them farther apart doesn't mean that you're actually going to cure the spasm that's occurring. That's number one. Number two, they talk about titanium. Yeah, eventually Dr. Shiki, when the procedure first came out, wasn't using titanium, but you can use almost anything to hold the thyroid cartilage, the front of it, apart, whether it be this, quote unquote, special titanium bridge or not. But the real problem with, in addition to the fact that I don't think it's very successful, is you can't inject Botox once you perform the surgery on patients. And many years ago, in the ones that I tried, because it was being popularized, the patients, they had so much scarring, and now with the advent of a titanium bridge, you can't really get the Botox into the vocal cords. So you've eliminated one treatment paradigm that actually is very effective, Botox injections. And so I hate to say this about any procedure, but I just don't think it's a good idea, and I wouldn't recommend it to any patients that have decided to try it.
So another question we have is regarding the Slat surgery, or the D-re surgery, as you refer to it. Can you talk a little bit more about that procedure and typically who are the best candidates for that procedure?
Sure. It's a procedure that, many years ago, Dr. Dito actually cut the recurrent nerve, and many of those patients got better, but also a significant proportion of them recurred with their dystonia within about two years after the surgery, or even less, 6 months. And the reason for that was twofold. Number one, he really could only treat one side, because you can't cut the main nerve on both sides. You wouldn't be able to open your vocal cords to breathe. But nevertheless, it did demonstrate that some patients improved by taking the the nerve away from the muscles of the vocal cord. The surgery itself is based upon the knowledge of the microneuroanatomy of the larynx. And what we realized is that we could actually go inside and find the nerve that actually goes to the thyroarytenoid muscle, where we inject Botox into it, and sever that nerve, and then reinnervate the muscle with a nerve that's not involved in the dystonia. It's a branch of the ansa cervicalis, which is the nerve that goes to the strap muscles in the neck. We have 8 strap muscles, and so it's a branch of that nerve, and we use it actually to reinnervate different parts of the larynx for patients with paralysis and different disorders. So it's a common nerve that's used for this problem. In any event, it was researched in an animal laboratory, and then eventually started in patients in the early 90s, because believe it or not, it was not that easy to get Botox back then. And we found that over the years, we've kind of revised the surgery and kind of removed some of the issues that kept us from understanding exactly how it worked. And so the surgery as it stands now is pretty effective. And when I say effective, I mean probably in the upper 80th percentile, especially for women. And we do it on both sides. We tried doing unilaterals for a while, but found that almost everybody that had a unilateral operation required to go back and do the other side to really get good results. It's primarily for patients that have moderate to severe spasmodic dysphonia that are less than probably 65 to 70 years old. The nerves don't regenerate very well when we get in, unfortunately, when we get into that age category. So we try and reserve the surgery for people that have the ability to reinnervate their nerves more readily. And we still do it. There's one of my fellows, Dr. Blumen, who's on the East Coast, who's one of my, I think he was actually my first fellow, believe it or not, back in the early 90s. He performs the surgery. I don't know how many he's done. I have taught the operation to a number of doctors, especially my fellows who assist me during the operation. And I think many of them are quite proficient at it. You know, it's a long operation, takes about 3.5 hours to do, and the patients have some swallowing issues for a while because we've removed the nerves, but they all regain good swallowing, and oftentimes their voices are very effective, and the surgery seems to be lasting for many years. Like anything else, you know, patients with spasmodic dysphonia, you know, they come in many different varieties, and there's abductor mixes with it and tremor mixes with it. And so not everybody responds to the surgery the way that you would hope that they would, but nevertheless, overall, I'm enthusiastic about it. And I think if you read patients that have it, for the most part, many of them feel like it's really been beneficial to them. Having said that, as I alluded to in my talk, you know, I think Botox is still the gold standard, and many patients that I've had for 20, 25 years continue to get Botox shots and are happy with them. I don't know, any issues, other issues about that? There was a question about evolve over time. Yes, so over time, we've changed it. We found other small branches of the nerve that go to other muscles that we needed to take into consideration, and it's very technical exactly how we've evolved the surgery, but nevertheless, I think we're down to understanding exactly what the best procedure is to end up with a successful result.
Great, thank you. And you had mentioned too about with botulinum toxin injections, and typically if somebody responds well to botulinum toxin injections, does that kind of help to make you determine if they're a good candidate for this surgery?
Yeah, Yeah, in fact, I think that's kind of the pre operative test that, if they have a history of at least having one or several Botox shots where they've found relief, then it looks like they will usually do well with the operation itself. And the other thing that I think when you're comparing that to something like the type 2, for those patients that don't end up with the result that I wish they would, they can go back to the shots. Nothing prevents them from going back to Botox shots afterward. And I think that's an important advantage in terms of wanting to try something like that.
Now, more recently, you've been working on a newer procedure that you refer to as a muscle revision surgery.
Yeah.
Can you share a little bit more about that, who it's designed for, and how you determine if somebody's a candidate for that particular surgery?
Yeah. So many years ago, again, back in the early 90s, for some of the patients that didn't respond well to the DRE surgery or the Slat R, um, I would go back in and actually cut the muscle from an external approach. I would go back through the same incision and open up a big window and actually take out some of the muscle, in which we termed a myomectomy, a removal of muscle. And technically, it's a difficult operation just because of the where the muscle is and the anatomy of the larynx. But nevertheless, many of those patients got good results from that. Um, but I didn't think that there was really any advantage of doing that over trying a Slat R first, because I knew that that was the operation that I had had the most experience with. Um, Probably about, I don't know, 5 or 6 years ago, the Koreans published a series, and also a group in Brazil published a series of doing a myomectomy, going right through the mouth instead of going through the neck to do it. And it seemed like it was a reasonable alternative to going from an external approach. And so I think we've done probably somewhere on the order of 30, 35 patients with it. And initially, we did some patients where we didn't actually take the muscle of the false vocal cord, but found out that indeed we needed to, and then kind of revise them through the mouth as well. For the most part, I think it's a good operation for patients that have mild to moderate dystonia, um, and um, and maybe some dystonic tremor, but certainly not a lot of tremor in their voice as well. And it doesn't take a long time to do. Um, the patients can swallow right away very easily, and essentially within about, I don't know, 2 weeks they can usually go back to work and resume activities if they so desire. And so for all those reasons, I think it has a lot of potential, unlike the Slat R surgery that is pretty technical, and very few otolaryngologists know the microneuroanatomy of the larynx. This operation is much more basic, and probably many otolaryngologists, or laryngologists, I should say, around the country could learn this operation and perform it, which would be an advantage because patients wouldn't have to travel long distances for the other operation. So I think for all of those reasons, it's an important operation to consider. As with anything else with spasmodic dysphonia, not all patients are alike. There's a lot of very subtle factors that have to do with their voicing, and so you know, I wouldn't recommend it for everybody, and we're actually looking at the results of it right now. But my impression is that it has helped a lot of patients, and I think it's something that we need to consider for future treatments also.
And just to confirm, this is for adductor spasmodic dysphonia, correct?
Right, yeah. They're really, I mean, I didn't mean to get into this, but um, it's conceivable in the future that you might be able to remove some of the muscles from the ones in the back that cause the abductor dystonia. But the problem is we use those muscles to open our larynx when we breathe, and so the it's a pretty fine line between uh, being able to get rid of the abductor dystonic changes and not affect the breathing as well. And nobody's really ever worked that out very well, but it's conceivable that that could be done through the mouth as well. Um, but you'd have to go back with some basic research to really look at that more carefully, I think.
Okay, great. Thank you. And again, with this muscle revision surgery, is it a long hospital stay? Is it less than with the slat R?
So the SLAT-R patients usually have to be admitted overnight and then one more day to make sure they're swallowing okay before they go. And they're pretty breathy for anywhere from 2 to 3 months, usually. The patients that undergo the muscle revision surgery, if we wanted to call it that, um, usually leave the hospital the same day, which is it's essentially an outpatient procedure. Takes about an hour to do, maybe a little bit longer. And so, that's, from my perspective at least, a very large improvement in our ability to hopefully manage the condition. As I said, it's not for everybody, but for those patients that seem like they have mild to moderate dystonia and maybe are tired of Botox and want to try something else, it's certainly a reasonable alternative right now.
Okay, great. And one question that we did have, this is a person who had a procedure, it was asking about if it's common to have a weaker, although clearer voice, and goes on to say that they fatigue easily from speaking, but the voice sounds good.
I think any procedure that you do to lessen the dystonic changes in voice will weaken the vocal cords some. I mean, there's no way around that. And so it's conceivable, yes, that some of the patients that undergo it may have a much clearer voice, but not be quite as strong as it was before. I think that's part of the price that you have to pay. And even with Botox shots, patients that undergo Botox during that time period when the Botox is starting to work, oftentimes have a lot of breathiness and weaker voice too. I think the good thing about maybe a myomectomy is that once it heals, the voice is pretty stable. You don't have the terrible up and downs that you do sometimes with Botox shots, which especially can be very detrimental in males that oftentimes will go from not having a voice at all to having their dystonia back without a long interval of good voicing in between, just because their vocal cords are more massive. And so when the Botox works, their voice goes away, but then as they gain some use of them back, the dystonia comes back very rapidly.
And before we leave surgery, any other surgical procedures for abductor spasmodic dysphonia that you have worked on or tried?
Yeah, a while ago, we had a series of patients, and we published the results of that underwent bilateral thyroplasties, which, by the way, certainly any laryngologist that knows how to do a thyroplasty could certainly manage as well in some patients with, again, mild to not severe abductor, but mild to maybe moderate abductor dystonia. And I think the results in some of those have been very useful. And the reason that seems to work is when you medialize, push the vocal cords closer together, it causes the person to use more force in trying to get his vocal cords to vibrate. And somehow mental impression that I need to push harder causes the vocal cords to close more readily and can improve the aural perception of abductor dystonia. So it's kind of, just as the vibratory that Dr. Konzak is working on, the vibratory stimulator seems to kind of cause a trick to cause patients to have less dystonia. I think in a way the bilateral thyroplasties kind of do the same thing in causing the body to kind of like respond to them and somehow kind of negate some of the changes that are occurring with the abductor variety.
And since we're talking about abductor, and I think you may have already just touched on it, what do you think is one of the most promising, less invasive than botulinum toxin injections, new treatment maybe on the horizon for abductor dysphonia?
Yeah, well, there's a RTMS that we discussed during the talk, and we've actually funded a study that's looking at the effect of repetitive transmagnetic stimulation on patients with abductor dystonia. I don't think the results are out yet for that, but that's certainly a non-invasive, or I would say limited invasive procedure for that, and could have a lot of utility if it's found to improve the situation. There's only two ways to inject Botox into the PCA muscles. That stands for posterior cricoarytenoid muscle, and because they sit on the back side of the larynx. So you either have to turn the larynx 90 degrees, which is pretty uncomfortable if you can imagine somebody grabbing your larynx and turning it 90 degrees to try and get the needle in the back of it, or you have to go through the larynx into the back of the cricoid and actually through the back wall of the cricoid, because that's where the muscle sits, and give the Botox. And it's not a difficult thing to do, but as I said, the real issue with abductor dystonia is this fine line between giving enough to weaken the PCA muscles so that the voice is stronger, and not giving too much so that the patients actually have trouble breathing because they're not able to open their vocal cords very effectively. So, the truth, really, the solution for that problem awaits somebody to do some really good basic work on. There's three bellies to the PCA muscle, and somebody needs to really study which bellies would be most involved in the abductor variety and figure out a good way of severing those or treating those in order to improve the situation of these patients. But other than that, let's see, oxybate. There's in some patients that have alcohol-sensitive abductor, they recognize that oxybate has the potential to improve the situation, but there are some negative issues with using oxybate as well. I think somebody asked a question about that. I'll wait till you get to it.
Yep, actually, that's the next one we were going to
Oh,
talk
okay.
about. And so the question was, it is currently being studied as a possible treatment for alcohol-responsive spasmodic dysphonia. And the question really kind of revolved around if a doctor can prescribe it for a person to try.
So the answer to that question is some doctors can. So because it is fairly addictive or thought to be very habituating, the doctors that are using the medicine right now have to basically register. So you have to, and as far as I understand, I don't know if any laryngologists have registered to use it, but there are a number of neurologists that have, and so you have to really go to them. So it's not like something where your doctor can, certainly your general doctor can say, here, try this pill and see if it works. It basically, when it does work, has activity for about 3 hours, which when you think about somebody with dystonia, 3 hours, if you went to a party and you took the pill ahead of time, once it started working, it's a little like Cinderella. You have 3 hours and then your carriage turns back into a pumpkin at that time. And so I have some issues with the concept of taking it constantly for this problem, but nevertheless, you know, unfortunately, I don't think you can just try it. I think the patients have to be registered right now, and the doctor that's using it also has to register the prescriptions, their ability to write a script for it. And I'm not, and again, having said that, I don't think every pharmacy would carry it also. There's probably very few.
So this is kind of completely moving to a different realm. Have you heard anything about LSD being used to treat dystonias and
I
spasmodic
saw the
dysphonia?
thing and I looked up. So LSD is being used, I think, with some patients for migraines, and also used in some patients with functional disorders. And by a functional disorder, we mean a patient that has a voice problem, but it's not physiologic. They're either conversion. The classic the classic conversion patient is a husband who brings his wife in and says, my wife can't speak anymore, and she's sitting right next to him, and it's obvious from the discussion with them that she never got a word in edgewise, and so she's finally just decided to not converse at all. And so it's a psychogenic illness, and certainly patients that have chronic depression, or maybe even patients that are bipolar, might sometimes benefit from LSD, but I could not find one listing in the literature in the use of LSD. First of all, LSD is a pretty dangerous drug, and I don't think you can get it. I don't think you can prescribe LSD anymore. So if you're asking me, is this illegal drug useful in SD? A, I haven't found any reports of it, and B, I wouldn't advise anybody to take a totally illegal drug to try and treat their SD.
Fair enough. I'm just reading the questions we got.
Right. Yeah.
So I want to shift gears again a little bit about some other issues. So is there any current views on the connection between MS, multiple sclerosis, and spasmodic dysphonia?
So it's well known among doctors that multiple sclerosis is the great imitator. And that is to say, patients with multiple sclerosis, because it's a kind of a neurodegenerative disease with ups and downs, oftentimes can come up with a particular neurologic condition that heretofore was not present. And that might last for a while and get better and go away. So the answer to that is, initially when they first started looking at spasmodic dysphonia, they thought maybe it was a peripheral nerve disease. That is to say, some of the patients that they initially looked at thought that the patients that developed it had something wrong with the coating of nerves, which we call myelin, MYELIN. But that doesn't seem to be the case. But clearly, I would think somebody with a case of MS that's kind of florid could indeed express symptoms similar to those with spasmodic dysphonia. It's the great imitation. You can imitate almost any neurologic disease you'd like to think about.
And so would the vocal, if somebody has vocal issues with MS, do you think it would be SD or some other type of vocal issue?
I think it would be because, yeah, multiple sclerosis affects a broad spectrum, but it would just be the fact that it wouldn't be due specifically to the speech center of the brain where there's some connectivity issue that's occurring. It would be probably more general. They have very, very generalized neuromuscular weakness and swallowing issues and speech issues. And so it's a pretty dramatic, widespread neurologic disease, unfortunately.
Okay. And we had a question about gasping syndrome and how common it is, and that does it become more frequent?
So I don't know exactly what they mean by gasping. I mean, there's an entity called vocal cord dysfunction. And there are certain patients, many of them that have asthma, that also have vocal cord spasm, breathing spasm. It's not speaking spasm, it's actually breathing issues because, and I may have alluded to this, the pulmonary stretch receptors can have a very large sensory input to the larynx and can actually contribute to the vocal cords closing when patients take a breath instead of opening. You can, every single subspecialty, pulmonologists oftentimes will call it vocal cord dysfunction. The ENT doctors call it paradoxical vocal cord motion. Actually, it's called paroxysmal paradoxical vocal cord motion to make it even a bigger name, but they're all the same disease. And basically what it is it's recurrent acute laryngospasm. I'm assuming that's what they're talking about. Having said that, yes, there are some patients with spasmodic dysphonia that are more prone to acute recurrent laryngospasm than other patients. And again, you know, it's a very complicated system of neurosupply to the vocal cords, but just in the way that some patients have dystonia involving their speaking mechanism, some patients have spasms involving their breathing as well. And believe it or not, Botox can actually treat that as well. And I have a number of patients with vocal cord dysfunction that come in for Botox shots as well to keep them from having to go to the ER and getting treated all the time. And it can be a huge problem. It's fortunately not super present, but it does exist. And patients with SD have a greater propensity to experience that than other people. Oh, and usually it's associated with pretty bad stomach acid reflux because the acid comes up, burns the larynx, and makes it more prone. And also associated with asthma due to the pulmonary stretch receptors. So we try and remove all the factors. And many patients find that when they're emotionally upset, that it's more prevalent as well. So we try to remove or lessen all these factors to see if we can get them down to being subclinical. And again, I'm not sure what they mean by gasping, but I have a feeling that's what they're talking about.
You covered a lot about botulinum toxins during the live presentation, but there were a few other questions that were not kind of directly related, but kind of around it. One of the questions is this a disorder that will get worse over time without Botox treatment?
That's actually a good question. And I would say the large majority of patients with spasmodic dysphonia, once the disease entity becomes clinically evident, the phenotype expresses itself, the disease will pretty rapidly come to some equilibrium with their ability to communicate and pretty much stays there. It doesn't seem to have this ramp up like some other diseases. It seems some patients have mild cases of it, some have severe cases of it. By and large, most patients have kind of an intermediate level of dystonia, but it doesn't seem to actually travel in one direction or the other. I don't, you know, most patients obviously are hoping that, you know, all of a sudden there'll be some kind of miracle thing that causes the dystonia to get better and go away. Usually doesn't happen. I mean, they have dystonia and it continues on. but the ability to respond to Botox over the years, which is really the important issue, seems to be pretty stable. Most of the patients that I have, unless they've developed autoimmunity to the Botox, it's not autoimmunity, I should say immunity to the Botox, will continue to have good responses to the same doses of Botox that they've been taking for many years. There is one thing that does happen. As you keep injecting Botox into the larynx, the structures of the larynx get more difficult to actually inject because there's fibrosis that occurs, there's calcification that occurs. And so when you follow a patient for 20, 25 years, maybe even 15 years, the actual structure of the larynx becomes less easy to pass a needle through. And it's really the skill of the laryngologist to understand where they have to go and how they're able to do that is important. But it does present, certainly to a novice, sometimes a real issue in terms of getting the Botox into the vocal cords itself. And so that's just something that happens over time. You just can imagine if every 6 weeks or 3 months somebody gets an injection into his muscles, there's going to be fibrosis and calcification that occurs, and it does.
Great, thank you. And another question, kind of around stopping Botox. This person was saying that they no longer receive the injections, and more often than not, it didn't work or was unpredictable. But when it did work, I noticed my thinking seemed clearer. I was able to use and recall larger words, and thinking was smoother. Do you think the spasms have anything to do with slowing down the thinking process?
There's some evidence that Botox can cross the blood-brain barrier, and some people postulate that maybe when you inject Botox into the larynx, that there's some kind of retrograde movement up into the neurons and the cell bodies in the brainstem where the nerve is exiting from, and something is blocked that allows it to work easier. I don't know the answer to that. I don't think anybody really does, but I could understand that from the perspective of somebody, people that have SD have this tendency to worry or be stressed out when they have to talk in extemporaneous fashion under certain circumstances. The classic one is the telephone. We always ask patients, do you have more issues on the telephone? And almost invariably they'll go, oh yeah, it's really bad. Well, why is that really bad? It's partly bad because you're hearing your dystonic voice in the phone when you're talking, but it's also bad because your body is somewhat stressed in terms of worrying about whether to get the words out and how difficult that's going to be. And clearly when the Botox is on board and all of a sudden your extemporaneous speech is back, I don't think you have the same stress level in terms of trying to communicate. And that does probably make it much more easy to remember certain words that you used to use and maybe bring them up from your conscious or subconscious mind into your extemporaneous speech. So I think that's probably more likely what's happening, but it's a good question, and I'm sure that occurs to many patients with SD.
Thank you. And along those lines, what methods are there for measuring the effectiveness of botulinum toxin injections outside of keeping like a diary or a tracking chart? Is there any other method of measuring the effectiveness?
Well, I mean, so again, when I gave the talk the other day, I alluded to the fact that we don't really have a lot of super effective ways of measuring changes in voice use other than some self-reported measurements where people kind of like have a scale that they can measure against, or keeping a diary. And so people are, there are a few acoustic measures that are purported to be useful in measuring patients' voices with SD. And as I said in the paper, the NSDA was very useful in funding a study that will be published in the Journal of Speech and Hearing Research, a really good journal, where we actually used artificial intelligence to grade just videos of patients and found that it corresponded with the degree of severity. But as of this moment and at this time, right now, no, we don't have a lot of really sensitive measures. In a broad spectrum, they have ways of kind of talking to patients and having them jot down different factors that affect their voice. But again, it's kind of subjective. It's not really that objective. It's really an important thing, because if I, or let's say somebody in another institution is trying something new to improve the situation, you can use these kind of subjective measures, but it's very hard to compare across institutions when all you're using are subjective measures. And as much as I hate to say it, many patients don't have a good understanding of what their voice really sounds like, or their speech really sounds like. None of us really actually hear our voices. We kind of hear maybe an echo of them or the vibrations in our head. But it becomes very difficult for an individual that's not trained in listening to speech and voice to kind of rate their own, other than for them to say, God, I'm really fluent now. I can talk and everybody keeps telling me I'm better. So, that's important, obviously. But objectively speaking, which is what medicine needs to use to really score things, we just don't have it right now.
Thank you. Switching gears a little bit, I have severe MTD, muscle tension dysphonia, and are waiting neurology to investigate if it is spasmodic dysphonia also. Recently, I was walking with a friend, and while talking, I had an audible voice, not perfect speech, still getting stuck with words beginning with vowels. Does this suggest that there may be a psychological cause, or could this still be neurological and therefore fit with SD?
So again, SD has, unfortunately, a number of subvarieties. So you have patients with just regular adductor. You have patients with just abductor. You have patients that have both. You have patients that have adductor or abductor with tremor. And some patients can actually try and compensate for their SD by what we call muscle tension dysphonia. And what that is it's the analogy that I enjoy using is, if all of a sudden you hurt your shoulder, eventually you might start using it in kind of a funny, irregular way, because you're kind of compensating for something else that happened. And even though the initial injury is gone, you keep using it in an improper manner. And so there are many patients that may have had a cold or COVID and have been coughing and their voices get hoarse, and they try and compensate for that. But when they get over the underlying issue, they continue to overcompensate. And so patients develop what we term muscular tension dysphonia. It usually can be dealt with by a good speech pathologist in a fairly reasonable period of time. Some patients, not every patient that has spasmodic dysphonia expresses the disorder as strangled speech with voice breaks. Some patients that have spasmodic dysphonia are just hoarse. And they respond, by and large, to Botox shots as well. And so there was a many years ago, Christy Ludlow had this meeting where we were talking about that. And Dr. Ludlow really wanted to define spasmodic dysphonia as strained, strangled speech with voice breaks. And some of us in the audience said, that may be true in 80% of the patients, but some patients just express hoarseness. They've learned to get around that. They just talk and they're really hoarse. They don't have the strained, strangled, but they respond really effectively and their voices clear up with Botox. So I would say that indeed, for that person's question, indeed, it may be that you have kind of one of these alternative subcategories of spasmodic dysphonia, and indeed may have spasmodic dysphonia. And really, the best way to tell, I think, or the simplest way to tell, is to see if you're responsive to Botox injections. Charlie and I, a long time ago, I was telling Mr. Rivas that, I'm almost at the point in my career that when I see somebody with a pretty severe or moderate dysphonia, as opposed to a dystonia, their voices just don't sound good, I kind of divide them into Botox sensitive and Botox insensitive patients. And if they respond to Botox, then they can be good candidates to get treatment. And in fact, the Medicare, which kind of like decides how to pay for Botox treatment, has decided that it no longer has to be spasmodic dysphonia to use Botox. They have changed their criterion to just spasm. And so patients that have spasm now can actually be treated with Botox. And I think that comes from a realization that not everything falls into these neat categories of abductor, adductor, plus or minus tremor, plus or minus muscular tension dysphonia. And I think that in a sense that's helpful for patients.
Definitely gives the physicians more options in trying to determine what is going on with the voice also.
Yeah, right. Exactly. Totally.
Well, we've got the one last question, and this is probably the one that most people ask a lot of, is where are we with the understanding of the cause of spasmodic dysphonia?
Well, I think we've made some incredible advances. I mean, 10 years ago, if you were to ask me that, I would say, gee, we're starting to do some really good research. But I think, and I talked about it, I think quite a bit in the last session that I did. I think it's pretty well understood that there are centers in the brain near the speech center that not only stimulate the lower neurons that go to the cell bodies in the brainstem to activate the muscles in our voice box and also our lungs, but there are also inhibitory cells in the cortex that kind of grade just how much force we want to use. So when I'm talking to you now, I'm talking to you with about 5 centimeters of water pressure. That is to say, I'm closing my vocal cords just so much that when I push with my lungs, they're closing them with only about 5 centimeters of pressure. But if I were to talk really loud, I'm using much more force and I'm closing my vocal cords much more. For some reason, the inhibitory area in my brain that is normally functions without me thinking about it, probably learned it when in infancy, when I was going gaga goo goo, gets poorly misset, or there's a functional disconnectivity problem that's occurring, and it's not controlling how much information or how many neurons are firing down to the thalamus and the cerebellum and the motor neurons in my brainstem. And so it's actually a question of a mismatch between what I want to say and the forces that I'm using to try and get that out to you with. I think that understanding that and knowing that is a great advance, because now we have a particular area of the body that we know is creating this connectivity problem that's contributing to the speech deficit that people are experiencing. And as soon as that happens, we have the potential then to really treat that and manage that, whether it'll be through RTMS, whether it'll be through future genetic modification, whether maybe some, brain stimulator or will work. I don't know, but I think the fact is, you can't fix something if you're not really sure where it's occurring, and we're pretty sure that it's occurring in the speech center from a connectivity problem between the foci that creates information going down to our motor control and an inhibitory area in the brain.
Great. Thank you so much. And thank you, Dr. Berke, for sharing your time, your talent, and all your knowledge with our community and all you do for us. We really do appreciate it.
Oh, it's a great pleasure to be able to talk to you. It's funny, once I start talking, I feel like I can't stop talking. I just my mind just kind of starts to flow over. It's like a fountain that's too full. But anyways,
Well,
thanks.
we appreciate it.
Yeah, I'll talk to you guys later.
Okay, great. Thank you so much. Take good care.
All right, thanks.